Bienvenue à tous. I am Marion Dove. I am the chair of the Department of Family Medicine at McGill, and I'm very happy to welcome all of you today to this third webinar in our Global Health webinar series. Today's webinar is entitled Digital Therapeutics and Virtual Expert Care Leading to Facilitated Self-Management. I'm delighted that we have two different sets of speakers who will be talking today about these very interesting topics. And the speakers will be introduced by Dr. Timothy Evans, who is the director of the School of Population and Global Health here at McGill. So this webinar series started back in January of this year, and it is a joint effort of the Department of Family Medicine with its Global Health Director, Professor Elaine Adams, and the School of Population and Global Health. And we've had tremendous success with these webinars, super interesting topics. And as Professor Evans says, they just keep getting better. So we are thrilled to have you all here today for this third webinar in our series. And with that, I will turn the floor over to Timothy Evans to introduce our speakers.
Great. Well, thank you very much, Marion, and I'd like to extend a very warm welcome to our speakers today. Terrific and really building on previous discussions. So thanks everyone for joining us. Our first speaker today is going to be Dr. Deneen Vojta. Deneen is the Executive Vice President of Research and Development at the United Health Group. She's an MD by training, but has significant experience in innovation and entrepreneurial activities, and is really very interested in reform of care models. So she's going to speak to us first. She'll be followed by Professor Albert Mulley and Margaret Mulley. The Mulleys are coming to us from Dartmouth, where Dr. Mulley is a professor of medicine and managing director at the Dartmouth Institute. And his spouse, Margaret Mulley, is in charge of health policy and clinical practice. And has a long history in learning programs, particularly in the private sector, where she worked with Deloitte for 30 years and was very involved in their efforts to mainstream continuing education and learning in their operations. So we'll begin with Deneen and then move to the Mulleys, and please populate the chats with your comments, and we'll take those in a formal Q&A following the initial remarks from Deneen, Al, and Margaret. So Deneen, over to you. Thanks.
Thanks for having me, and good afternoon and good evening, everybody. I thought I'd start by to contextualize in my comments would be just a bit about United Health Group. United Health Group is a multinational corporation, and we have, that's sort of the parent company, and we have United Health Care, the insurance companies, and to that end, we serve the Medicare, the Medicaid, and the commercial population, predominantly here in the United States. And then we have Optum Health Services, which actually has three main parts. One is health services that help the health system work better. So think about all the intel inside of running health systems, et cetera. And then we have Optum Care, which is actually our direct delivery of care. So we serve about 10 million patients in 43 states with multi-specialty practices, but a large part of those are primary care physicians. And then, of course, we have entities in Optum, such as, for example, the PBM, and they administrate and organize the delivery of prescriptions, as you know. So that's the corporate, again, United Healthcare, Optum. And then the third leg of the stool is research and development, my favorite. And research and development, we are about 850 people. full of mathematicians, data scientists, physician scientists, lawyers, of course, finance folks, all dedicated to figuring out what the best care possible is. And if you think about that, you have an opportunity to say, if you were actually redesigning the entire system to deliver the best care possible, not the best care out there today, you would be reimagining what care is. It's literally how it's defined, but also how it's delivered and where it's delivered. So I thought I'd start by, and by the way, that 850 people, let me put in the context of UnitedHealth Group, we have 330,000 employees. And just in the US, we actually serve 140 million people. So it's a big organization. And so and because we serve Medicaid, Medicare, and commercial, we have a responsibility to do that, to get the best clinical outcomes at the best price possible, so that both consumers and the plan sponsors, whether that's your employer or the government, gets the most out of their healthcare dollar. So as we think about reimagining what care is and where it's delivered, I want to start with a concept articulated beautifully by my friend and colleague at Penn, David Ash. And he wrote a really lovely article, I think in 2019. I'm happy to send it to y'all. And he began to describe this notion of facilitated self-service. And if you think about it, every part of our lives, we facilitate our own blank, fill in the blank. The example I always use is banking. I'm old enough to remember when every Friday night in the 1970s, I would go with my father to the bank and he would deposit his check. He would take out a bit of cash for his, for the week and deposit the rest. And, you were in line with the whole neighborhood. And now we can't imagine doing banking at anything else but ourselves. And yet, when we do have a problem, there is an escalation path. Usually it's that 1-800 number, 1-800 US Bank, or 1-800 Wells Fargo. And when that doesn't work, you still can go into a branch and get the help you need. And again, David articulates this beautifully, saying, it's amazing with all the technology we have, why haven't we in healthcare embraced that notion, again, of facilitated self-service? And he argues that it's less about technology and mostly about the social construct that we have in healthcare. Now, fortunately for his thinking and our thinking, we had a natural experiment in the last year that we could have never designed, and yet it allows us to take advantage of blowing up the entire system. So, and i.e. the pandemic. And, what we saw was, how many people were not actually getting services all of a sudden. They decided that, they weren't going into the hospital. They weren't going into their doctor's office. We saw actually a 75 to 80% reduction in cancer screening services, colon, breast, and cervical during particularly say March to May. And so all of a sudden, again, we had to quickly reimagine what care is and how and where it's delivered. And so, and again, the notion is that with the right technology and supplies and content automation, that's another really huge part of all this in getting to facilitated self-service. The notion that every interaction in healthcare requires a patient and a physician is healthcare's choke point. And so, and we have to sort of be willing to step away from that, and what parts can actually be automated and allow me to securely and safely take care of myself with all the right stuff. Again, whether that's wearables, automated bots in my own home. So my house actually becomes the doctor's office. So, but again, and I always remind people still need people, and there always has to be an escalation pathway. So I'll tell you, one great example that we had already started and then we're able to, put on steroids during this pandemic was a business that we developed out of R&D called Level 2. And this is the notion of giving people living with type 2 diabetes control and belief that they can actually put their condition back in remission. So what we do is these are, again, people we already have responsibility for. So we already get, we get a yearly premium from the federal government or some employers to take care of people. So we said, okay, people living with diabetes, we're actually going to give you a CGM, so that you yourself, so it's not that isolated finger stick, but you can get 288 readings a day. And actually, for the first time in your life, understand, when we as physicians say, oh, you should eat less and exercise more, what does that mean? Well, when you wear a CGM, which I did for a couple weeks, and I could see that, even, and I'm not living with dysglycemia, but I could actually see, how exercise affected my sugar levels, how stress affected my sugar levels, how much I slept. I'm somebody who never wants to eat after 5 o'clock at night, and I know why now. And it's because when it was a business meeting or something, my sugar levels never really came down nicely. And so I tossed and turned all night long. So when you give people this kind of wearables, and we give them an activity tracker too, they begin to see how they can change their lives. And I'm going to get to a facilitated self-service comment here too. Is one thing we see people do is they change the timing of their medication. So say I'm somebody who eats ice cream at 7 o'clock every night, and I'm unwilling to change. Well, one thing, because our physicians, and by the way, this level 2 is set up as a physician practice. So we have physicians, nurses, and of course then we have an extended care team, but that can actually give advice and to say, okay, what do you do every night, Deneen, at 7 o'clock while I eat ice cream? Are you willing to stop? No. So I said, okay, let's move your metformin from the morning to the early evening. And so we see if we can get that to stabilize, the fluctuations in your sugars over day. Just fascinating. And then what we're able to do is, from all that data coming in from the CGMs, is to begin to create algorithms so that they're a bot generated advice. So that is simple things. Okay, I can just see you just had a meal. I can tell from your curve. If you have a chance, get up and go walk for 15 minutes and watch how it nicely brings down that curve. So, and what's wonderful, because as a lot of type 2 diabetes is behavioral health, in addition to the physical health issues. People begin to say, okay, you know what? Do I want to add a pill, or am I willing to walk 15 minutes after I eat? And then I can actually begin to wean off some of my medications. So just fascinating. Additionally, as you know, a lot of insurers and the NHS, we all have these formularies of tiered drugs, et cetera. What you quickly begin to realize is, when you have that kind of streaming data coming in, is you can understand, like, wow, I can see who would benefit from an SGLT2, say, for example, or a GLP versus a sulfonylurea. And you have a good argument from the data itself saying, wow, Deneen responds best to blank, not what's on the formulary. That doesn't make sense at an individual level. So super excited about that. And while level 2 has started in type 2, if you think about it, it's a platform. It's a platform for leveraging wearables, remote digital expertise with real humans, and driving to facilitated self-service. So, and that can be for any chronic condition. And I'm going to argue that is a far better way of taking care of real people living with chronic disease than compared to these sort of quarterly visits that make, in my mind, absolutely no sense at all. So why today? Why this quarter? Versus I should come in when I need help. So, and we've all been there. So then the other notion that I think this facilitated self-service and how do we get to the best care possible is, and something that we don't actually discuss often in healthcare, is this notion of early detection and interception of disease. The entire healthcare system around the world is based on treating disease often later stages. So, and I joke when I give this a presentation to others and saying, okay, here's a trick question. If you're going to have colon cancer, do you want it to be picked up in stage 1, or do you want it to be picked up in stage 3? So weird. Nobody ever picks stage 3. And how do we do that? Well, I think we actually have to, again, go back to what are the care models that exist today? And let's start with colon cancer as an example. So as I said, we had a 75% reduction in colon cancer screening from March to May. And again, I'll remind you, we serve, hundreds of millions of people. That's a bad thing. And, but one thing what occurred to me, and I'm a pediatrician, so I hadn't really given this a ton of thought, was that somehow, at least here in the United States, colon cancer screening had become synonymous with colonoscopy. Simply not true. As you know, there are 2 other options for home-based testing. All of them save lives. And so what we quickly did was we organized ourselves, and we looked at all of our highest risk folks, and we knew everybody who was not getting screened, and we actually just went ahead and sent them a home-based test. We offered to set up a telehealth visit if they wanted to, to walk it through, and we actually were able to, get people's, gaps in care checked off. But equally important, and more importantly, is that we were able to pick up some cancers earlier. So instead of, ignoring it for a year and letting that year go by, we were able to actually serve that population. And I know in other countries, they actually do use the FIT test first, but it is fascinating. When I turned 50, and again, I should have known better, but I'm low, I'm average risk. There was no reason I should have gotten a colonoscopy. And instead, I can take off work because of my job. I can do all the prep. I can afford everything. But even pre-pandemic, we know that 32% of people opt out of colon cancer screening. And that's because, it's synonymous with colonoscopy. The other thing it allows you to do, and I'm going to watch my time. Okay, I'm almost done, is allow you to rethink actually guideline care. So if you look at those guidelines in that Chadwick Boseman, who unfortunately passed away, African-American male, and died at 43, which means he was diagnosed at 39, that if we got all this information and leveraged the data, I think we could come up with much better guidelines for different types of people. And I'll end by saying one other example we did in the spirit of, again, early detection and interception of disease. We learned from the Brits that in the spring that 50% of people over 65 who were co-infected with both flu and COVID died. And we found that unacceptable. So we actually put a box together called Well at Home. And in the box was a generic Tamiflu, a thermometer, a 1-800 number for telehealth, and then a COVID collection kit. And basically, with the instructions, if you have any of these influenza-like symptoms, call us. And if there's a lot of flu in your community, we'll say open the Tamiflu, and either way, we'll get the COVID collection kit. And fascinating, in the first 8 weeks, we sent out 400,000 kits. We had 8,000 telehealth visits, and 31% of COVID tests were positive. That compared to the average in those communities about 10%. Just so completely blowing any other metric out of the water. And I hope you can see I'm excited about this for the future. Thank you, and thanks for having me.
Great, thanks, Deneen, and a whole set of really interesting examples of how that care model is shifting, and as you say, to facilitate its self-service. So lots of opportunity there. It reminds me of the recent visit to Israel, where studies of the gut microbiome are showing how managing diet can be tailored to individual microbiomes and manage glycemic levels much more effectively than prescribing a one-size-fits-all diet. And I think this is indicative of the movement towards precision and more opportunity to tailor guidelines to individual needs at home. So with that, we'll switch over to the Mulleys. Al and Margaret, over to you.
Okay, I'm going to start. And what we're going to try and do is to provide really two big ideas that relate to the use of digital or any other technology or redesign of care, particularly primary care, in order to improve that care by improving decisions. And the two big ideas are simply that we don't pay enough attention to the quality of decisions made in the face of uncertainty in clinical practice, and we don't pay enough attention to the kind of teamwork that's necessary to support really high quality decision making. And then finally, the way this relates to digital is in paying not enough attention to decision quality and the teamwork necessary to achieve it, we lose the opportunity to learn from all of the good choices that could be made in good quality decisions. And that's a critical intelligence that we need in order to make healthcare sustainable everywhere. So that's pretty much what we're going to do. We're going to use a bunch of slides, mostly visually, but first we're going to tell you a little bit how we came to work together, a little bit more than Tim already told you with our introductions. I was at the MGH for I was at Harvard for 40 years, at the MGH for 35 years. And for almost 30 of those years, I was chief of general medicine, responsible for both the acute care, including intensive care, hospitals care, and primary care. And we had half a dozen community health centers that were very much modeled after community-oriented primary care that came out of South Africa in the 1940s, the first established in 1960. And my work was influenced by training in economics that I did while I was in medical school that had me focusing on decision quality and the expected utility model of decision making. I'll stop there for now, Margaret.
Okay. And I come from a completely different background. I was at Deloitte for 30 plus years, as Tim said, and much of that time I served clients, but I also ran innovation and strategy. And for my last 5 years, I was asked to be the chief learning officer. And that was really an epiphany for me to really make sure that all of our employees, I was responsible for about 14,000 of them, actually had the tools so that they could do their job. And how did we do that in an effective manner? And that really influenced things as I started to work with Al and the team at Dartmouth, because so much of the academic work tends to be, pretty theoretical and high level. And my urging to Al was always go out to the front lines, go talk to the people who actually deliver service, go talk to the people who are receiving service, that there's never any substitute for being there in the community, understanding what the community is like and what their needs are. And how do you build then education programs that make sure you're right there at the coalface?
I'm going to tell one story very, very quickly at one particular coalface. I was attending physician in the intensive treatment unit, intensive care unit at MGH for a decade. And I'll never forget the epiphany I had coming back from a family meeting where we were discussing whether or not to do a tracheotomy in order to continue artificial ventilation for somebody who was almost surely going to die of end-stage chronic lung disease. And the epiphany was that although we, the team, students, residents, myself, I think handled the meeting very, very well. And came away with a very, very good decision from the family's perspective, and it was consistent with what we thought was best for her. The epiphany was that, maybe the probability she would have survived was 2%, 1 in 50, but it didn't matter whether it was 1 in 50, 1 in 500, or 1 in 5,000, because that decision was much more sensitive to the where, when, and how she wanted to die, and how her family felt about that. And having learned what I learned from economists about making decisions, it's about what options are available, what are the probabilities of different outcomes with different choices of one option or another. But equally important is how people feel about the outcomes, the people who are going to live with the consequences of the decision. So that was the first use of the distinction between warranted and unwarranted variation, something that you may have heard of. With that as background, I'm going to share a screen now, and it gives you a sense of why we chose the title for this brief set of comments. Primary care as the learning front end of the health system. If we make good choices, working with patients, understanding what matters to their health and well-being, those choices become critical information for system leaders to understand what capacities to invest in across the system, what kind of workforce planning they should do, what kind of workforce is necessary to support the kind of vision that Dina has for the use of digital technology, not only in the US and Canada, the UK, but globally. So primary care is the learning front end of the system, making choices matter for health and well-being. Now, I had the opportunity when I came to Dartmouth, I was recruited by Jim Yong Kim, who was here for a couple of years before, maybe a little less than that, before President Obama asked him to lead the World Bank. And the resources that brought me to Dartmouth gave me the opportunity to intentionally try and learn from across the globe, multiple countries, what was it that was universal as opposed to context sensitive in healthcare. And we did that in Salzburg and a whole host of other ways. We did it in collaboration with the World Bank Institute and another number of foundations and other academic medical centers. And we ended up focusing on theoretical ideas, but giving it some purpose and practicality by focusing on populations that were vulnerable because of mental illness, vulnerable because they were nearing the time when they were going to die, vulnerable because of frailty, vulnerable because of something related to a stigma. And we did that in Salzburg about 7-8 years in a row. And Margaret was with me for all of those meetings except the first.
Right. And I think what was interesting about these, the topics were all interesting, but there was a common thread that ran through, I think, each of the seminars, is that the participants really resonated more with with the stories and examples of real people and their experiences within the health and care system, irrespective of the topic, much more so than theory and data. They were eager to know what other people were doing about things. And they were also eager to know what did and didn't work well, so that they could begin to think about what kind of responses they had tried or they might try when they went back home. So although it was a wide-ranging group, they could very much come together around some of those very front-end issues.
So we came away feeling that there was a strategic intent that was universal, and it relates to decision quality. Across contexts, the strategic intent of the system should be to learn from variation in outcomes and costs by making visible underlying processes, learn from variation in per capita rates of different interventions. The Dartmouth Atlas, the NHS Atlas are depicted up in those maps up at the top. The Dartmouth Atlas 1996, the NHS Atlas 2010, showing threefold variation in per capita costs of care. In the US between, for instance, Miami and Minneapolis, in the UK, for instance, different geographic regions caring for patients with cancer or heart disease. So we also have to learn from variation in per capita rates by making visible preferences. The warranted variation for Mrs. Jones was how she and her family felt about where, when, and how she was going to die. That might be very different than how Mr. Smith's family across the hall felt about those things. And that's what makes care personal. That's what makes it humane. And if you look at that triangle down at the bottom, there's a way to expand that. You know, policymakers in the NHS, they're called commissioners. Margaret and I have spent much of our last 5 years together working with the NHS. And this notion is the base of that triangle is that there should be no avoidable ignorance in the exchange of information from health professionals to patients and family about what's realistically possible. Nor should there be any easily avoidable ignorance on the part of the health professionals about what matters to the patients and what they value, what trade-offs they're willing to make or not willing to make. And if you use some simple patient-reported experience measures, does the patient feel like they were helped to understand their condition? Do they feel like they were listened to learn what matters to them? And do they feel that what matters to them was considered in planning the next step in their care? And use a measure like Collaborate, which asks those three questions and provide the feedback, most of all, to the health professionals so they can hold themselves accountable, but also to the people who are responsible for the system-wide decisions. And if you begin to measure decision quality with that kind of experience measure, you can then measure it by understanding how informed the patient was. Could they answer the 2 or 3 questions that demonstrated they understood the trade-off? And was the decision aligned with what mattered to them? That alignment is incredibly important. And if you can demonstrate the quality of the decision, presto, you've got this commissioning intelligence, is what it would be called in the UK. But it's the kind of intelligence all system leaders need in order to determine where to build capacity. Otherwise, it's the built capacity that drives the decision making. We drive the nails because we have the hammers. We place the stents because we have the cath labs. Now, the teamwork piece of it, I told you there were 2 big ideas, decision quality and the quality of teamwork necessary to make good decisions. When I came to Dartmouth, I insisted that we start from scratch in building a new model of primary care. I'd had the opportunity to build multiple models that made incremental progress at the MGH, and I wanted to do something much bigger. We decided that we would double the amount of per capita spend on primary care from the healthcare spend for Dartmouth employees, double it. And at the same time, we would have the amount of time they would spend with clinicians. So instead of 4 GPs to care for a group of employees, we would have 2. Instead of 2 nurses, we would have 1. We wouldn't have any receptionists, and we would hire people for their relational skills and make sure that they had plenty of time, often working side by side with the clinician, with the doctor, as you can see, but expanding the time from 10 minutes to 30 minutes with the doctor there for 5 instead of the 10. So the whole notion was we're going to build a learning front end by making patients heard and making the decisions that are consistent with what they care about, and then learn from the choices that are made and implemented, as I've just described. Just very quickly now, this is the other big idea, and then we're almost done. We're just going to show you a proof of concept. Difficulty of the task is along the vertical axis. Level of competence necessary to perform the task is along the horizontal axis. The 45-degree line becomes very interesting, doesn't it? Everything below it is potentially inefficient. Everything above it is potentially ineffective or even unsafe. Usually when you talk to people in primary care, people in secondary care, and say, think about the people who help you care for the patients when they're in need, specific need. And usually it's the neurosurgeon or the cardiovascular surgeon who is up in this zone here, right? Very difficult tasks, very high levels of competence. And you know, we primary care docs might be here somewhere, but the truth of the matter is we're usually operating way below our license. And that's because we don't have the kinds of people I was just describing to expand our capacity to do the listening with patients, or to expand our capacity to do all the paperwork that needs to get done. But anyway, if you then say, just as a teaching moment here, you then say, okay, well, we fill this two-dimensional space with the people we work with in various ways, with the highly technically skilled surgeons up here. What if we focus on technical difficulty and technical competence? How does that change things? And it doesn't. But that's just so we can then say, well, let's qualify it as relational difficulty and relational competence, and that changes everything. No one puts the neurosurgeon up here when we're talking about relational competence. He's usually working all day with people who are anesthetized, right? So where does the social worker end up in this? Where does the social worker who understands talk therapy extremely well? They're right up here. Okay. And there are lots of examples. We won't take the time to talk about this. It's just the importance of understanding that this teamwork is incredibly complementary, and there has to be measures of that teamwork that measure mutual respect, common purpose, and good communication. Just very quickly, over on the left, we've got technical skills needed to make good diagnostic decisions by using probabilistic reasoning to take a prior probability, the conditional probabilities of the diagnostic test, and come up with a posterior probability. And we know that nobody does that well. Instead, we have these standard operating procedures that lead to bad decisions with people underestimating the importance of the prior probability in determining the posterior probability. Now, that's a wonderful use for digital tools. Those math mistakes should never, ever happen, and they happen more often than not in all of our GP practices and all of our offices on a daily basis. It happened when I wrote the first edition of Primary Care Medicine in the mid-1970s, and it's even worse now. Over on the right-hand side, it's, do you have time to listen to the story? Do you have time to know what's going on in the person's life and why they're presenting at this moment in time? And if you think about the importance of that when you're trying to address local context, the context in which somebody lives their life and the social determinants of life, social determinants of health and well-being, isn't it important to have that time to listen, to learn that, no, she really wasn't complaining of increased hip pain. What was really the problem is she couldn't get down the stairs because her banister broke. And the lonely woman was even lonelier because she didn't get to talk to the postman every day, or that the dog died. It's not an increase in depression. So this notion of having more time to understand what people are going through keeps you from replacing hips rather than repairing banisters, or adding antidepressants rather than comforting someone who just had to put a dog down. Now, what I've described is the strategic intent of what we think is important for every health system in the world, and that's in the center there. I'm not suggesting it's easy. There are conceptual challenges, there are operational challenges. We don't have time to talk about them now. We did talk about delivering with teams. But the other thing I want to say is that these 6 phrases here are 6 of 8 essential capabilities that we've been using to teach across England for the past 3 years. And we just taught a course stuck here at Dartmouth. We just taught a course to graduate students called Policy for Clinicians using these 8 essential capabilities. We added one to develop a logic for learning at the beginning, and then learn from variation, deliver what's valued, deliver with teams, measure what matters, organize for innovation, and lead for mutual accountability, followed by govern for stewardship. And this is the proof of concept we have to offer. This is where we worked most recently. Margaret, why don't you tell them?
Yeah, right now, much of the work we're doing is in the Black Country in the UK, which is a sort of hollowed out former mining towns, a great level of deprivation in that community that's long-standing. And with life expectancy far below that of pretty much any other region in the UK. So the goal that that the leader of that practice, that region has, is basically to improve life expectancy of the citizens. One of the ways he's doing that is with an academy. Do you want to move the slide along? And they'll just give you an idea of the of really the terrible plight that many of these people are in the life expectancies at this point, and the healthy life expectancy for folks, and how that compares to other parts of England. But one of the areas we're helping primary care teams reimagine how they do things to allow them to work in teams and to bring new workers into the workforce with those relational skills. Because right now the view is that much of the training isn't really fit for purpose. So we're working with them to work with their further education colleges. In the US, we would call them community colleges, to make sure that there's a workforce that can be added into the physicians and the nurses that will provide the time and the skills to engage that population. And also, as technology is being introduced into their care, how to use that more effectively. Clearly, we're working in a region where people don't have the same level of access to technology as they would in environments like we're in at Dartmouth, or probably you are at McGill as well. So that's a big part of our goal with that academy at this point.
And then finally, this was just sent out a week or so by the leader of the academy, a woman who we had worked with in developing this course a while ago, who rose to this new position. And you can see that they are focusing on the importance of decision quality at every level. And you can achieve good decisions at the top of the system or in the middle management of the system if you allow the easily avoidable ignorance in the exchange of information at the front lines to persist. It just can't happen. You never address the underuse and the overuse, and we're talking about serious underuse, not fixing the banister, and serious overuse, replacing the hip instead. So we'll stop there and see where that takes the discussion.
Great. Well, thank you so much, Al and Margaret, and what a tour de force. Big focus on really the supply side in terms of decision quality and quality of teams as the two primary drivers of this. Some nice examples of how that's landing, and a great compliment to Deneen's focus on facilitated self-care. Really complementary. So the floor is open. We've had some active discussion in the chat, and Juan Carlos, Luis, you've said a few things. Do you want, we can go directly to your chat, or would you perhaps you'd like to just address the issue viva voce? Would you like to talk, or would you like me to paraphrase?
You can paraphrase me. That's quite okay. You can go ahead.
Okay. So I think this is could be responded to, but it's really this, and we've got a family medicine group model in Quebec, and the question really is with HMOs and insurance companies, do patients under Medicaid or under other specific programs get assigned to a medical home? And so it'd be great if we could get that. Deneen or Al, and Margaret, any thoughts on that?
Well, let me just say, Dean, I'm sure knows this, but the practice that I described at Dartmouth was actually the first clinical partnership for Iora Health. And Iora has been very active in working with Medicaid Advantage, Medicare Advantage programs, and so they do capture a registered list in that way. Obviously, the registered lists are a critical advantage that GPs have across the UK, and is probably a significant reason why they ended up being heroes in getting the country vaccinated as quickly as that's happening.
Okay, thanks. Deneen, anything to add on that?
Yeah, I'd add that, it's super interesting. It's obviously a great model and for care. And yet, if you look at, there are certain organizations, I'm not going to name them, but, it's easy also to sort of pick off particular populations where it's very profitable, right? And that there could be other populations that are less profitable. So I knew one medical practice that somehow, and this is actually a true story, they decided to go at full risk and in accountable care, had the medical home, just beautiful. But somehow everybody at one particular academic center, the transplant department notified their entire transplant panel to go, oh, this is great care, you should go over here. Well, needless to say, they went belly up in about a year. You know what I mean? So it's, so I think that it's just harder than it looks. And so, yes, I think that the notion that all of us should be operating at the top of our license, that one's to me like a no-brainer. And yet, even on that case, if I'm only seeing, I'm a pediatrician, and if a lot of pediatrics, I think we could all agree, it could be easily be delivered through advanced practice nurses, maybe just RNs. But the reality is, as pediatricians, we often like those visits, right? It's wonderful experience. And so there's just always just more to the story. So
actually, let me just push back a little. The Iora model, or the Atlanticare model, Atlantic, if you haven't read the paper in New Yorker by Atul Gawande, about the Atlanticare model and the Camden Coalition, I'd commend it to you. If there's some kind of sharing of the savings, these models do far better when they're dealing with the kind of population you described, the transplant population, the populations that are very needy. It was the neediest patients who were working for minimum wage in Atlantic City that the model began on, and their improvement of outcomes, their reduction in costs was astounding. It becomes very difficult for them to achieve those kinds of savings when you're dealing with a Dartmouth population that looks an awful lot like Margaret and myself, just because there isn't the opportunity to reduce all the underuse that would prevent illness and reduce all the overuse that is waste and nothing.
That's my point, right? And so you said two things, and I'm not sure people understand this who aren't in, don't sit where I sit or don't sit where the NHS sits. One is shared savings is very different than taking full risk. Right. Yep. So apples and oranges, had it been a shared savings model, you're right. So, but, a lot of people think they're going to go to full risk. And again, you have something like that happen and all of a sudden you are out of business. Right. So but there's so many nuances like that. And then to your point, if you look at, the two of you and me, we're on a shared savings model, you're not going to get much. So it does come back. So to me, it's fascinating. Just look across the country and look at how people set it up. And everybody's targeting a particular bucket, particular population with a particular model. Even, and by the way, Jeff Brenner, as you know, worked for us for a number of years from the Camden Coalition, right? And we learned a ton from him. And he's back in Philly now. But, there's just the worst thing I think a message for these young students could be, there's more to this than you think. It's hard. And there's a reason that's we are where we are, and that, you're doing your life's work and learning from other countries. To me, I think the model would be the Buursdorp one in the Netherlands, right? fascinating. That is a nurse-driven model, for primary care.
So,
And you can take risk off.
so let's pursue this a little further. There were questions about lifestyle and the extent to which individuals in different circumstances can exercise decisions that are good for their health. And a suggestion in the chat that actually some people who are in higher education and income strata may have more decision capability versus those who are in more difficult circumstances. And I hear that in Deneen, it'd be great to get your sense of the facilitated, the patient facilitated facilitated self-service model and how it's sensitive to differential decision capability of the individual. And Al and Margaret, you've been dealing with greater at-risk populations in the Black country. So how is that interfaced with respect to decisions and the individuals that are involved in those decisions? How is that manifesting itself? Deneen?
I mean, I think we've never really tried to, whether the person has, in my world, we tend to group people by the categories of their insurance often, whether the Medicaid, Medicare, commercial. It is, again, disingenuous to suggest that they're not completely different populations from socially, from economically, etc. But that's not okay just to say, well, we really can't do this in Medicaid. We don't take that attack. If you look at my level 2 business, we take all comers, full risk. And then it's up to our team to get these people to help engage with them in a way with empathy, with shared decision-making, to help them help themselves. And it may look different than it would for you, but it's not an excuse.
Great. Any thoughts on this, Al and Margaret?
Yeah, no, I agree with what Dan just said, and I'll tell a couple of stories to make the point. And the reason this effort with the Further Education College is so exciting to us is their goal is to work with us and others in the Black Country, West Birmingham, to identify a way of recruiting people and bringing them into a curriculum and then into an apprenticeship. And then a certification program. And these people would have little or no background in healthcare. We're not talking about nurses. We're talking about people who are really clever, but didn't do well on their exams when they were 11 and 16. And then you're sort of out of the loop, out of work, out of the loop and out of work. So it's that they're recruited for their relational skills and given the technical skills, ideally with a lot of digital support to avoid those math mistakes that we make every day, right? So it's a very different way of thinking about the workforce. The woman who's pictured in those two slides was working in a Dunkin' Donut shop selling coffee, and she had the good fortune of selling a cup of coffee to Rashika Fernandopour. And he recognized the relational skills, hired her. She spoke Gujarati, and she became the lead coach in Atlanticare. So that's a very different model that we're moving towards. And the argument for it is two. One is we underestimate the capability and the hunger for agency that people living in deprived circumstances have. I'm going to tell a story that Tim can anticipate. First of all, let me say that I grew up in Chelsea, Massachusetts. It was the poorest community in the state at the time. My parents were immigrants from Newfoundland and Poland. Both interrupted educations in the 8th grade because of the Depression. And look how fortunate I was. So from my point of view personally, it's going and looking for all of the people who didn't get the big breaks that I got and give them this inclusive economic growth opportunity in these poor communities by changing what healthcare looks like. And the other argument is, you mentioned shared decision-making. There are more than 100 trials, many of them using the programs that I developed in the 90s. And think about cognitive behavioral therapy. There are many, many more trials. Think about motivational interviewing and how well we know that works as long as there's time to listen, and keep the person talking about the discrepancy between their near-term behavior and their longer-term goals. Why don't those things happen? because we haven't designed the workforce for it to happen, right?
Mm.
And Dean, if you think about the role of digital in the curriculum that we are building, and in the training and in the apprenticeship and all the way into practice in these sites, you know, it could be transformative. And again, the goal is to learn from the good choices that are made and implemented, because they reflect the very subjective value that people are choosing for themselves and their health and well-being when they're given the opportunity.
Great. Thanks, Al. I'm going to give you a little bit more of a task now, because I'm conscious that there's so much in the in the chat. I want to get it out, and then you can triage how you're going to manage it. But first, there's a real interest in understanding public-private mix, and whether these innovative models, how that interaction works. And so Deneen and Al, it'd be great to get your thoughts on different contexts is how do we make that, how is that system working, or how could it work? The second is Juan Carlos for the Mullies is interested in the kind of decisions that are made in primary care to those made in hospitals. And do you feel decisions or costs and consequences are in completely different worlds? So is there a neat break between the big hospital and the primary care setting? And then we have another question related to the 30-minute encounter and then 25 minutes. This is for the Mullies, for a patient. Who is the someone else that are involved, and who is the rest of the team? So you've chatted about relational workers, but is it just relational, or what is that composition? And I think that is where I'll stop. And now I know, Deneen, you've got a hard stop at 1, so why don't we begin with you, and then we'll move to Al and Margaret.
You want? Sorry, you went through a lot. Which one do you want me to answer?
I think the public-private mix would be an interesting one for you, and to the extent to which you can navigate that, I think that would be.
We're in the public-private business. So if you think about it, we serve our biggest customers, the federal government, right? And so in Medicaid and Medicare, and I have to say I think it's just fantastic how open. I'll use CMS as an example. How open they are to new care models, new ways of doing business. And what we often bring to the table is, we don't have all the good ideas, but what we are really good at is executing. So once there is a strategy and a plan, we execute at scale. And so, and I find that often when I think about the public health community, and we saw this during the pandemic, they've been underfunded forever, and they don't have the kind of skill sets that an organization like United Health Group does. And so, and there are other groups that do too, but just the sheer horsepower of, when you have 330,000 people who are very good at executing and are like, sometimes I speak at public health, I think, well, raise your hand. There'll be 1,000 people in the room. If you're in operations or in finance, zilch, no people, so, and I think that's part of the problem. I think we have to get, different skill sets in to solve the problem. And frankly, when we have conversations again with our public partners, it goes remarkably well.
Yeah, great. Thanks, Deneen. And just for on the call, it's the Center for Medicare and Medicaid Services, which is part of the Department of Health and Human Services of the United States. And so that's a public sector sort of think tank on new models of care. So I just wanted to make that clear. Great. Well, thank you, Deneen.
Yes.
I know you have to sign off. This has been tremendous. And so thank you very much. We'll get to the Mullies in a second, but I just wanted to thank you for taking time. Really fantastic to learn about what you're doing. And thanks for sharing it with us today.
And I'll put my email in the chat. Take care.
Fantastic. Thanks, Deneen. Okay. And Al and Margaret, over to you.
I'm going to try and touch on all three quickly, going in reverse order. The way the 30-minute encounter works is that, so the notion is if the average is 10 minutes for a consultation, as it is throughout the NHS for a GP, and you have five of these new workers for every GP, you've tripled the amount of time that they have to listen to the patient. Teams are sometimes rejected by patient teamwork. There's a fair amount of reason to believe that if the patient can actually see a highly functioning team that is designed to really get to know them and make them heard, make them feel known, they really like it. And so it's making the team visible as opposed to this MDT that brings the people together outside of the view of the patients. That is an important piece of this. So you begin the 30-minute visit with maybe 15 minutes with the coach, just catching up. If you've seen them before, how are you doing with this, and the other thing, and what are you going through? And you learn whether or not the dog died or whether the banister broke and things like that. And then you're dealing with the health issues as well, ideally supported with decision support of the kind that Dina was talking about. And then the clinician, the doctor comes in, maybe it's the nurse, but usually the doctor in our setting. We both get our care at Dartmouth Health Connect. And that's maybe 5 minutes where the patient and the coach together paraphrase to the clinician what they were talking about and where they're proposing to take it. And the doctor either makes an adjustment or affirms it, the plan, and leaves. And then the last 10 minutes is with the coach, so that everything is clearly understood and the next steps are known to the patient. So that's the way the 10-minute visit becomes a 5-minute visit for the doctor and a 30-minute visit for the patient. The second thing, the question about, I did say that I attended in the intensive treatment unit for a decade. I didn't say that I had a primary care practice and attended in the in primary care for 35 years. And I actually think that the decisions made in primary care are where we have the most to learn, and where we have a great deal of quality improvement to do, as I referenced with regard to Bayes' theorem and likelihood ratios getting honored in the breach, right? So the reason I say that is that's where all of the clinical cascades start. If the GP doesn't have time to listen to hear the banister broke, the patient gets referred to an orthopedic surgeon, might have to wait a long time for that. They're not going to miss the appointment. And then they know they're going to have to wait a long time to have the hip replaced, so they're not going to say no to that. And there's very little perspective. There's very little context when you get down to see the specialist, when you get downstream there. So there are all of these clinical cascades. There are a lot of clinical cascades and poor decisions made about screening. So I would argue that if you really want a functioning healthcare system where you reduce underuse and do the things that make life better for people, you reduce the overuse and the harm and cost associated with it, the decisions in primary care are the key ones to focus on. And then finally, with regard to public and private mix, we are currently trying to broker in the Black country a public-private partnership akin to what I was involved with back when we were trying to develop shared decision-making in the 80s and 90s. And the notion was we created a not-for-profit foundation that would be there with a board to attest to the integrity of the decision quality resources, the evidence behind it, to be sure that it wasn't influenced by pharmaceutical companies and technology companies. So you're preserving the social good component of it. And then we would find a commercial partner who would recognize the value of that, recognize the value of being able to say, look, we've got all these academics who are willing to work with us because, and that commercial partner over a period of a decade shared more than $100 million in royalties with the not-for-profit foundation, which made the ongoing support and research and development of shared decision-making possible during that decade. So I think there are all kinds of models of public-private partnership, and some of them don't involve as much profit-seeking as others, and some of them share the value created in the form of public goods that go to the community.
Thanks, Al. we do have, I'm sensitive to time. Marion has had to drop off because she had another commitment, and I realize others will need to move on quickly. Very interesting comment from Juan Carlos related to, I think, the broader determinants of health and the recognition of their power, and that one needs to look at and think about how they can do their job, which doesn't necessarily enter into the realm of primary care. If I'm paraphrasing you correctly, Juan Carlos. And I think then Mark Roper has an interesting question on, in this day and age where confidentiality is and privacy are such important concerns, how do you manage that when you've got such a large team involved and so many different organizations? And Al, you may just have a quick reflection on that. Is this something that is entering into this actually a constraint or a bottleneck or a growing issue that we're going to find in models where you've got larger care teams and more access to information on individuals?
Well, for the sake of efficiency, given the time constraints, I'm going to answer those two questions in a linked way. I think the confidentiality issues are large or small, depending on the level of trust between the patient or the citizenry and the people caring for them, and being heard and listened to and feeling known is an important part of that trust. And I think that links very closely to the social determinants. One shouldn't underestimate how much the social determinants aren't a reflection of people dealing with constraints that condition them to believe that their choices don't matter because they're so constrained. If you have no choices, it's hard to believe your choices matter for your health and well-being. And so I think that this notion of recognizing personal agency, giving people the benefit of the doubt that you can bring them to a level of competence to use it well, regardless of their background and what assumptions you may be making about them. The story I didn't tell, Tim, very quickly was the one about Vamajele, and I just raised that again. Somebody who'd worked in the mines of South Africa for 18 years, brother and sister still working in the mines. And I asked him the question, would you still have gone to the mines if you'd known what the risks were of tuberculosis and HIV? And he said, of course I would have. But if I knew that the risk was going to grow year from year to year, I could have decided how long I was willing to stay. Right? And who would have made the assumption that Vamajele could have thought like that in a heartbeat, right? He recognized the cumulative incidence was going to reach a point where he just didn't, that was his unacceptable risk level. And I'm saying this because we do it all the time. We underestimate someone's agency, we underestimate their competence. And the third component that's so important, the third foundational element, is a sense of relatedness. And their relatedness to you as a partner in the decision making, their relatedness to the people who are going to live with the consequences of an outcome that happens to them.
Great. Well, listen, Al, thank you very much. I want to thank everybody who's been active in the chat and everybody who's listened to this. I think just a really super interesting session where there's an opportunity for understanding different models of care, how we can get to better decision, how that can be shared and co-owned. And also, I think very importantly for the academic world that is engaged in these calls is that there are new ways of driving our educational enterprise, which may allow us to respond more effectively to the health challenges we're facing. And I think that's really inspiring in Margaret and Al, your focus on the learning enterprise, on bringing new educational innovation into the healthcare arena from places that one might not expect it. And I think that's what's so refreshing. So I'm really incredibly excited by this. I'm going to go to our equivalent of Dunkin' Donuts, Tim Hortons, right now, because I'm sure I'm going to meet somebody there who's going to teach me so much and provide perspectives on how we can rethink and re-energize and revitalize our healthcare system. So Margaret and Al, Deneen and Abstentia, thank you so much for making this a really exciting and interesting discussion on new models of primary care. With that, I'll draw this to close and thank again everybody for joining us today.
Thanks for having us.
Thank you all. Thanks for having us.
Cheers.
Bye.